2, presenting when I worked for the Alzheimer's Association. So it's nice to be able to do something like this again. So I've done a lot of talks about dementia care and Alzheimer's, but this is actually kind of a new thing for me to talk about hospice, although I'm not new to hospice. So today we're just going to kind of go through, and I'm hoping to dispel some myths about hospice and some things that, that word that tends to scare people. I heard someone just mention, well, I don't know if we'll need it, but, it is scary when you hear that word. Sometimes we think, oh goodness, that means our loved one's dying very, very soon, like within the week. And as we know, I know when I was growing up and you would hear the term, well, they went home and they called in hospice. That was like everybody's, you knew that was the end was near. And sometimes still that is the case. You have some folks that maybe have had cancer or another illness where they have been fighting with radiation, chemo, and then you see those situations where the doctor says there's nothing else we can do. They decide to stop, and they give them only a matter of weeks to live. So we do take care of folks in that situation. But a lot of, one myth is that hospice is only caring for people with cancer. And that is just not true. We're going to kind of go through, and I'm just, going to talk about these things. If you ever have a question, feel free to just, interrupt. You can just raise your hand and say, we'll go through it as we go, okay? But hospice is, and palliative care were put in place by President Ronald Reagan. And the hospice that we look at was, at that time, it's my understanding that if you were on hospice, you had to die, you had to be going to pass away within 6 months. I mean, that was just the hard, fast rule. If you were on service for 6 months and a day, you were discharged. It didn't matter really what your status was. That's my understanding. So people have this in their heads that 6 months, that's all I have is 6 months. Often that's the case. I'm not going to say it's not. And it's something that we look at. But as you see here, there's no crystal balls for diagnosis. We've seen, you've all heard those stories of folks that we really didn't think would be living very long, and then all of a sudden they're living for years. And so, there's not a crystal ball. You don't know. But we're going to go through, first of all, here talking about Medicare and the fact that Medicare sets these guidelines. And I just want you to be informed of what the benefit is, because it really is a great benefit that we're offered through Medicare and Medicaid. They cover everything 100%. So it's good for you to know what's out there, okay? So Medicare sets the guidelines. The guidelines are interpreted periods of certification. When somebody, we'll talk about the process of a referral, but if we had a referral for someone who was for a hospice referral, and we went out and evaluated them and found that they met qualifications and criteria for the hospice program, then we would go through 2 90-day certification periods. So that person is certified. They can come onto our program in 90 days. The nurse will come in. They'll look and see, are they still, have they improved? We do have hospice graduates. That's something that people kind of think, oh my goodness. I have a woman that does my same job in the southeastern side of the state that herself was on hospice. She's my age. She's a hospice survivor. Okay, it's one of those situations where she had breast cancer, double mastectomy, went through some experimental treatment that they didn't think was going to work, and it did. So, there are those cases, that happens. So after those 2 90-day periods of certification, then we have to look, that's that 6-month period, we look and say, okay, are they still, in order to keep qualifying them, we would have our doctor or, the physician go in to their home, to the facility, wherever they're at, and re-qualify them, say, are they still meeting criteria? Most times they are, so they recertify them, and then from there it goes every 60 days that they have to look at the individual. So it can go on for a long time. I know we have people in our service that have been on for over 2 years, and they continue to meet qualifications. Because if they don't continue to meet qualification, we have to discharge them, because that's sometimes just the way it goes. Okay? So that's how Medicare interprets those guidelines. The physician certifies a terminal status. Okay, so you hear terminal. What does that really mean? Well, you're looking at a condition that cannot be cured. So we all know people probably that carry their oxygen around all the time because they have COPD. When they get up to move around, they get really short of breath. Their oxygen stat drops. A lot of those people will qualify for hospice. Now, it's a mindset as well, because if there's something that cannot be cured, it's something like an end-stage COPD or congestive heart failure, or if the doctor's getting to the point where he's like, I'm doing everything I can just to maintain you, but really there's nothing that I can do that's going to really make you better at this point. We're just going to have to look for comfort. That's a good cue for you or for your family to think, okay, well maybe we should look at hospice. Do they qualify for that? Okay. Again, the 6-month prognosis. This is a Medicare guideline, no crystal balls. That is something that people have very strongly have in their minds that's what we're looking at, and that's just one of the things we look at now. And then the benefit is designed to continue past 6 months if the patient continues to qualify. As I said, we do the recertification periods every 90 days and then every 60 days from there with the doc. So sometimes we have situations where people are discharged because they've improved enough. I have a lady where I was administrator last that we put on service when I was administrator there. Frankly, I didn't look for her to make it past her first 90 days. She was declining that much, and it's been over 2 years, and we're looking now that she's actually improved so much, we're thinking, does she even still qualify? So you have to look at those things, and sometimes it happens. Okay. Payment for this. This is the benefit that's so great for, hospice staff, medications, durable medical equipment are 100% covered by Medicare or Medicaid. So this is a wonderful benefit. So if anything the patient needs for their diagnosis, now if they have other things going on, like say we bring them on service for COPD because they're having trouble breathing and all of that kind of thing, they're end stage. If they're a diabetic, we're not going to pay for their diabetic supplies, but we'll pay for anything oxygen, medicines relating to that diagnosis. That's another, kind of a myth that people have, that hospice comes in, they take people off everything. Well, that's not what we do. I mean, that's something that we would look at and say, is this medicine helping them? Is it, what's best? But we're going to try to help them to maintain that quality of life as best as possible. So hospice will come in, they'll pay, Medicare, Medicaid will pay for medications that have to do with that diagnosis, treatments, and the medical equipment. So if they're in the home and they could use a hospital bed just because, they have trouble breathing. A lot of people with breathing problems have to sleep in a chair because of that, because they can't breathe. We can bring in a hospital bed. We can bring in cushions, like for so they don't have breakdown. We can bring in the pens. We supply like incontinence products. We can supply Ensure if the person's having trouble eating and they need to get some calories. We can supply that. Shower benches, even lifts, things like that people would have to rent or go out and buy, wheelchairs, walkers. That's all something that we order when we admit somebody and they're delivered, and you don't ever see a bill for that. So it's really a great, great service as far as the financial benefit. So hospice admission guidelines. So if, people will say a lot of times, well, I get this from referral sources a lot. I don't know. What if I think somebody might qualify, but I don't know? We always just say, just let us know. Call us and talk about it. If you refer a patient for evaluation when you see one or more of the following. A big one is weight loss. That's something you tend to see towards end of life. People start to just lose weight. They don't have as much interest in eating. This becomes a very big stressor for the caregiver because, in our society, we feed people. We love them, we feed them. That's just how we, and we like to eat. Well, towards end of life, even the last few years of life, many times, and I'm sure you've seen people in your life start to lose weight. They just don't have that same desire to eat. It's not like, research has shown it's not like starvation. Like if you or I were hungry and we were not fed for a period of days, we would go into starvation mode. We would be very hungry. Their body is actually going through the process of gradually shutting down. They're not hungry like we are. And it's not, yes, we need to make sure to try to feed them, and yes, we need to make sure they have liquid hydration, but don't be alarmed if they just don't feel like eating, because that's just kind of part of it. Reoccurrent infections, especially pneumonia and UTIs. If you're seeing that frequently, a lot of times folks that are wearing incontinence products, you'll see, especially if they're living at home by themselves or having trouble, the adult children may say, gosh, mom and dad just keep getting these UTIs. Well, it may be how clean are they able to keep themselves? Are they drinking enough? All of those kinds of things you're going to see at times with end of life. Increasingly frequent trips to the hospital or ER. How many of you have had to go to the ER and then seen the bill? It's kind of scary, right? You go in there and it's like $5,000 to walk through the door, it seems like. Well, a lot of these folks that have the congestive heart failure or have the COPD or those chronic illnesses, especially when they're getting very, very bad, they'll be going into the hospital, once a month or more, just to the ER and try to get regulated. That's something that, and with payment issues with Medicare is not, happy, or Medicaid, either one, when they have to pay a bill when that person's going back in. It's called that readmission, and if any of you are involved in healthcare, you know that the case management of the hospital, that people are saying we've got to reduce our readmission rates, and it's because of this payment issue. So they don't really want to see the same person back over and over and over again because it's hard for them to get reimbursement. Significant decrease in ADL performance. That's activities of daily living. They start, they're not able to really bathe themselves, to cook for themselves, to just, get to the bathroom, to, all those kind of things. Or using oxygen much more, or continuously. This tends to be a pretty good rule of thumb for me. I have a nurse that says, if you see someone on oxygen that has to be on oxygen all the time, that's one of your first things, to think about as far as this person may qualify. Now, not everybody that wears oxygen full-time would, but a lot of folks will. That's just something that is considered life-limiting and may very well lead to being qualified for hospice. Okay? So again, continuing the admission guidelines. This is something else. If you know someone who's oxygen stat, everybody's had the little oxygen clip on their finger when you go to the doctor. If that is less than 88%, like if they don't have their oxygen on and they're less than 88%, or if they get up to walk from their chair to the bathroom, and we've all seen people that really wears them out, and you check it and it's 88 or below, that's a huge qualifier for hospice. Increased heart or lung symptoms with activity or at rest. That, again, is just that, it just wears them out to go take a shower or cook a meal or anything like that. No longer being able to walk. This is something we see towards end of life too, that, I have a lot of families that'll say, well, gosh, Mom was walking until about a month ago, and now she's just, I can't get her to get up. It's real hard. She's just feels like she's very weak. That's another thing to think about, is that qualifying. And no longer able to communicate basic needs. We think of that a lot of times with dementia. That's one of the, actually before end of life, that's something that we see. But if you're helping care for somebody that isn't able to communicate their basic needs, that's another. So all of these are kind of rules of thumb to kind of look at. Okay? So, what I would like to encourage everyone in here is that if you're just asking for a hospice screen or a family meeting, does not commit you to anything. So if you said, well, gosh, I'm looking at your list, and my mom sounds like she may have a lot of that qualification. We're caring for her at home, or but it just sounds kind of like her. I would suggest calling, and there's many hospice agencies. I work for Premier, but there's many in town. But we would come out, and the hospice agency would come out and do an evaluation, which basically just means they come in, they kind of talk to your loved one. Do a few of these little tests on them, like checking their lungs, they'll check their oxygen, look at their diagnoses from their physician. And many times we can say, if you're interested, this is what we could do for you with hospice. Okay? So that's something that I would encourage you to do. And it's always good to kind of have that baseline, even if the person doesn't meet criteria right off the bat. It's good for you to say, the nurse could say, well, they don't quite meet criteria, but if this happens, give us a call back. So, in doing that, it helps you to clarify the patient's condition, help the decision maker understand the benefit. People, again, I know you all are here to, gain this knowledge, but there's so many people out in the community that hear the word hospice and they just automatically tune it out because I'm not ready for that, I'm not going to talk about it. Okay, so that's what we're trying to dispel that myth. Increase the comfort and peace of mind of the patient and family by removing the fear of the word hospice. And to understand, and I love this line, hospice is a concept of care. It truly is. If we evaluate somebody And we say, they say, we would really like mom to have some physical therapy. We're thinking that maybe she really wants to try to get that. Well, great. What we're going to do then is we're going to refer them to a home health agency. And Medicare also will pay that 100% to come in and to do the home health. Now with home health, the person tends to need to be homebound. They look at that more than hospice. They have to be homebound because they're trying to meet the goals in order to get them better, and then they discharge, okay? So that would be, that's something that you can use kind of in conjunction with looking at these things. Okay, can we get mom or dad better as far as using therapy or these other treatments or changing medicine, and then see how they do. Well, if the home health comes in and they do theirs and they're like, your mom has plateaued. That's a word they use, which means basically this is as good as we think she's going to be. We don't see that she's going to be able to progress past this. Or they'll say, she's not meeting goals. Or they'll say, hey, she's met all the goals we have. Then they have to discharge because Medicare will only pay as long as that person is getting better, okay? So when they get to that point and they say, well, there's nothing else we can do for you, many of the home health agencies will then in turn say, I'm thinking with her qualifiers, they could really benefit from having the nurse come in and the aide come in and having this oversight of care in the home. The mom doesn't, grandma doesn't want to go to the hospital anymore. She's tired. We just want to keep her comfortable. Well, when you start to get to that point and you feel like they pretty much plateaued and they have these symptoms, then that's the time to call us and say, let's come and look at them and see if they qualify. Okay?
And that's an in-home?
It can be. We take care of people in homes. We take care of people in assisted livings. We take care of people in independent livings, in nursing facilities. Everything is a little different. In order for a hospice agency to give care in a nursing facility, they have to be contracted with that facility. And I think most facilities in this area are, if you don't have a contract, are open to that because they have different agencies. So sometimes we start in the home, we follow people to a facility. Sometimes, we've had situations where people are in facilities and are able, with our help, to just get the person back home for the last few months of their life because that was their choice. We're all about what is going to be best for that patient. What does that patient really want? So it's one of those things to think about before it gets too late. If you're like, well, we're not there yet, it's good to go ahead and think, what is the goal? Mom, what would you like for your final days? What do you want, what kind of help do you think you would need? And kind of look through this because it's not always, people aren't always able, if you work, you can't be two places at once. So sometimes you have to look for housing or facility for your loved one. But we can go to any and help with that. So hospice diagnoses, this is kind of a, whoops. Let me do this. Okay. I broke it, Mary.
No, it was broken before you got
Oh.
here. I'm not sure I can help you.
Okay. Well, I have if nothing else, I can talk from my
You might
side.
have to do that.
Okay.
I'll see what I can do.
Okay. Everybody just kind of refer to your hand out there. Okay. Get this. Okay. As far as hospice diagnosis may include. Now, for Medicare, when we go out to evaluate somebody, we will look at, there's certain diagnoses that Medicare will say, this is considered life-limiting. If they meet A, B, and C criteria, okay, you can admit them to hospice, okay? So the first one here we look at is ALS or neuromuscular diseases. If they are now just because they have those diseases doesn't mean they're going to qualify for hospice, but if they are to that certain level or certain point, they can. Dementia. Dementia is kind of a broad term. We all know people with dementia that are still out driving cars and are functioning pretty well. They're in early stages. Obviously, that's not just in itself going to qualify you. But when the person gets towards end of life and they're having issues with, ambulating, they've had a lot of falls, they've had a lot of infections, they're having trouble, they're speaking kind of in a word salad, we say. Like you're saying, how are you today? And they say a few words, but you can't really make sense. It's all jumbled. They're not able to control their bowels and bladder. Those are the things when a person gets to that point with dementia, many times they will qualify for hospice, so we can look them under dementia. We help a lot of people at assisted livings because so many people want to age in place. That's the big term nowadays. They say, gosh, I don't want mom to have to, they've lived at this assisted living for several years. I don't want them to have to go to a nursing home. If we can help it, I don't want to do that. Okay, well, what we can do sometimes is with our oversight, coming in the home, checking on them, working with the assisted living staff, we can actually be that skilled bridge through end of life so they can stay there. So we do work with a lot of assisted livings. Stroke or coma is something that is a diagnosis that if it's to the point, well, obviously coma, but stroke, we can do that. Liver disease, renal disease, kidney disease. If a person is, on dialysis and then they just decide, I can't do it anymore, that's when we would probably step in as far as being, because as long as they're on dialysis, it's great. I mean, I would fight too, if it were me, but as far as dialysis goes, if a person's on dialysis, the insurance companies look at that like that's, you're trying to, extend your life with that. So they wouldn't pay for hospice and for that, but if a person decided to go off of dialysis, then that would be the time that we could step in and make sure comfort was there. Cancer is another one. That's the standard you think of for hospice, but just having cancer in itself wouldn't qualify you. There's people with cancer that live for years and maybe even opt to not have treatment, but they're still functioning pretty well. But if there's certain qualifiers with the weight loss and things of that nature that if they had and did not want to seek treatment, we could help them as well. And then the last we had here was HIV or AIDS. So supporting documentation. We have the BMI is below 22 kilograms. How do you calculate BMI? You look at a person's height and their weight, and then you can kind of see where they're supposed to be as far as that scale. And if they are actually under a certain level, that's a supporting documentation for them to look at and say, that this person has lost weight. When a person loses weight like that, they're more easily prone to having bed sores because they're not getting the proper nutrition, or they may fall and their bones may be more brittle and they may break something. They're just more fragile. So that's something we look at. Is declining or refusing nutritional supplements. Has anybody ever cared for a person towards the end of life and they just say I didn't want to eat? Okay, so you know what that's like. It's just they just don't want to eat anything. They're not hungry. Weight loss of 10% or more in the last 6 months. This is something that happens a lot. I evaluated someone this last week who actually had a 10% weight loss really in a month. I mean, she had just really dropped weight drastically, but we look at that within the last 6 months. And most assisted livings and doctors, if they're going frequently in assisted livings or nursing, they have to do those monthly weights. So we can kind of look at that and see. And weight loss is weight loss is causing significant disability, including total care with activities of daily living. So that's, those are those things too. How is mom able to get up and walk? If someone with dementia, they say, well, yeah, they can walk, but we have to really hold on to them, and they would pretty much fall if we weren't there. They didn't have a supportive device, then that still would qualify. Okay. This next slide, I love this. There are 4 kinds of people in this world, and this was a quote by Rosalind Carter. Those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers. So basically, the caregiver is going to fit in somewhere, I know recently my mother-in-law passed very suddenly from a heart attack, and not only with that loss was that very tough on us, because we were totally out of the blue, she was a caregiver for 3 elderly people in our family. And so now all of a sudden, guess who one day became caregiver? Myself and my 2 sister-in-laws. Became a caregiver for 3 folks that really need it, plus plus working full-time, plus having children, and that adds a lot of stress all of a sudden, because you have to worry about their needs and adds to you too. So it can happen to any of us very quickly. Sometimes, like I said, eventually we'll probably, unless, you have a, sudden death or something, I mean, most of us will need a caregiver at some point. So good thing to think about. Okay. Any questions so far? Anything?
No questions, but I've gone through hospice with our 39-year-old son, 6 years ago. So then they didn't have the new home, and so when the hospital in Indy sent him home, and it was, everybody knew he had a month to live. I mean, he didn't think that. I mean, he had that much faith, but
Sure.
so we had to decide, you know, do we keep him home or do we send him somewhere? But we decided to keep him home. And then at some point, the doctors all said, you know, they sent us around and they'd all say, oh, you know, we need to call hospice in, but our daughter wasn't for that, and she gave him constant care. And so we did live a month, but hospice came in and brought us all the things that we needed.
Yeah.
And, yeah, we just gave in to it, but when he did pass, then they had just gone, and,
Yeah.
you know, he was gone then. But,
Sure.
yeah, so, yeah, we've experienced it, and it's just the way you talk about it, the way it happens. But they were all so, you know, just wanted to bring us that last month. They wanted to do everything for us at our home.
Sure.
But like I say, my daughter was in healthcare, and she said she would do
She
that.
wanted to do it.
But they did come to assist us the last few days, and it,
Was
yeah,
helpful.
it
Well,
really
and
works.
you know, and that's just a good example of that's what worked for your family.
Uh-huh.
And if it does, then great. You know, it's
Yeah.
not a situation that has to be for everybody, but I think it's just important for people
Yeah,
like
and
you to
so
know.
he also, the good things about him, he knew what was happening to him,
Mhm.
but he was still able to take care of himself.
Yeah.
And so, you know, even though we had to feed him and everything, and he was on nourishment, but he was still able to get up and shower, take care of all of his personal needs. And, but we did experience it, and, you know.
Yeah. Well, and thank you for sharing that. And I'm
Yeah.
sure and it's so different as a child, losing a child like
And so
that. It's just-
everything that we had left from him, that any supplies or anything, then we just took it into the local hospice, and they accepted,
Oh, that was
you know,
great. Sure.
some of the things that,
Some of the things that you
yeah,
had.
so
Right.
we just gave it, yeah, so
Right.
it does happen.
Right, right. And that's one of those situations that, you know, I totally understand, and you were able to take care of
Yeah,
everything.
yeah.
One thing with hospice is too, we have folks that will kind of follow your family with bereavement,
Yeah,
even
yeah, they
13
were
months
always there
after.
for us to call them if
Right.
we needed them, so.
Right.
So it was a sad ending, but a happy.
There is something
ending.
about that.
Yeah.
Well, Mary, did you have a question?
Can you talk about the hospice house and how the different companies relate to that? And
Sure.
like if you're on hospice with one company
Yeah.
and when you could switch and that kind of stuff?
Sure, that's a good thing. The hospice house here in town, I've not been in this one, but I've heard it's beautiful. It is through IU Health Hospice. So that's, if you were on Premier Hospice, unless you were to transfer to that hospice, you couldn't. I mean, they don't let us take our folks in there. I guess is what I'm saying. But it's a nice place. Through the end of, there's people, the way I understand it, if they're looking at this person's probably not going to make it more than 14 days, then at that point they're kind of thinking death is imminent. You know, they use those words. Then they will, if the family says, you know, we're at home, but I'm not comfortable with with them being here in that state, they can transfer them to hospice house. A lot of times in the hospital, if the person has, you know, been being discharged from the hospital, they meet that criteria, they'll set them up with their own hospice or the IU, and they'll take them to hospice house. And it allows families to be, not like I said, I've not been in this one, but I've been in several of them before. And they're always set up to kind of have the family be able to stay there with them, kind of just, it's quiet, it's serene, it's just meant to be, you know, a very calming place. Now, that being said, while we don't have our own hospice house that we would take our patients to, most of our folks, what I find is a lot of times people just want to go home, whether it be they were in you know, nursing home or assisted living, and not always, you know, that is their home. I'm not saying we would take them out of there, but say they were in the hospital and they're like, I just want to go home. So what we can do there is very similar. If they have a need that's out of control that we need to stay with them, Medicare will allow us to bill them for like 4 to 8 hour increments of, I think it's 8 hours, increments of care for continuous care, where we can be right at their bedside. We can make sure they have everything they need. A lot of hospices will do general inpatient if symptoms are out of control, where you would contract with a hospital or with a facility that had 24-hour nursing coverage and could actually have them there. So what we would do prior to getting to that point, we would want to talk to the family and kind of gauge, what do you feel comfortable with? You know, if there's a lot of, I mean, when my dad was passing, we had him at home, and that's what we wanted. We were able to be there. Mom was in her home. The family was there. That's what Dad wanted, and I'm so thrilled that that's where my dad, where he passed. I'm glad it wasn't in another place. But there's people that say, oh, I could never go back in that room if I was in there when Mom passed. You know, so you just have to see what your comfort level is. And then there are agencies, like you said, that you could go to the hospice house if you're on that specific hospice, or you can look at maybe being transferred to a facility. Does that make sense? So kind of either way, you would do either like the hospice house or the general inpatient or continuous care. So don't feel like, I've heard people say, well, and I don't want to sound like, I don't want to be political. I'm just saying if they go to IU, they're like, well, we have to go with them because they have the hospice house, and you guys, I just want you to know other hospice agencies will still come in and do the continuous care that's needed towards the end. Okay? Yes.
And I learned this spring that if you can switch hospice companies like every 60 days or something. So like if you came out of the hospital and you were in the hospice house, but then you wanted to go home and you wanted to switch to like Premier or another company, you can transfer. So
Sure.
yeah, Medicare allows you to switch companies, hospice companies every
and
60
if you
days.
if you transfer, it doesn't interrupt service.
Right.
The one stays with you until the other one picks you up. So that's an option too. I mean, it's kind of like your physician or something. If you're unhappy, you're not tied in forever with the same company. You can look for something else. You know, they all are pretty much the same, but you know, everybody, it's just like facilities or anywhere, everything, you know, you have to go where you feel comfortable. Okay, so the next slide, some of these are just talking a little bit about, we get a lot of questions about these types of things, and I know some of these slides may be a little bit kind of shocking, but I think it's good for you to remember and understand what's happening towards those end of days. So learning to reposition a patient in bed is important if you're caregiving at home because of the need of the breakdown of the skin. We don't want to allow someone to lay flat on their bottom for weeks because that obviously would probably cause a pressure area. The elimination of urinary and bowel. By this point, a person is very frequently incontinent. So, you know, having the proper incontinence supplies, you know, having if a hospice was coming in, they could do those skin checks and teach you how to reposition and teach you, like, I know with my dad, we did, you know, they taught us how to do like the different pillows, you know, between the legs and just different things like that that you may have seen but you wouldn't think about. How to manage pain, you know, that's something, that's really what our goal is, to have people have a good, you know, good quality of life versus while we can't supply the quantity, we can try to help with the quality, making sure that they're not in pain. Managing nausea and vomiting. With the pain and the nausea and vomiting, I know with our service, when we bring someone on, when they're ready for it, or if it's, you know, if they're needing it, then we supply a comfort kit where we have like liquid morphine, liquid. We have like Ativan for anxiety. We have suppositories for pain or for pain or for, you know, constipation. Those types of things, because we want to make sure the bowels continue to move when there's not much activity and when the person is in bed a lot and when they're not eating a lot, the bowels tend to get sluggish. And so we want to make sure we're having a bowel movement every at least 3 days to make sure that there's nothing, because, you know, we don't want them to be in pain and have an impaction and all of that. How to manage fatigue and sleeplessness. You know, all of those are types of things that we want to look at. And the nurse coming in, the nurse, typically a hospice nurse comes in about twice a week. If the person has a symptom that's out of control, we can even do daily visits, even on the weekends. We have a 24-hour on-call service. where the on-call can actually, you can call at 2 o'clock in the morning and say, you know, I'm just real nervous because mom is just breathing different, I'm not sure what to do, and our nurse would come out and would take a look at her and make sure that you're comfortable. So it's just having that extra set of that help. And then to kind of go back there with morphine, this is something else too that I've heard recently, and I don't know if any of you have heard this before, but it kind of shocked me. I was bringing someone on, and their adult son said, well, are you guys bringing that morphine in basically just to kill my mom? And it was kind of shocking when I heard that. I thought, what? I felt like, it's almost like we were Dr. Kevorkian or something, doing these. And so we had to explain that, his understanding was that before death, they would just give a big dose of morphine, and that's what, hospice was. And I thought, wow, so that worried me. Now, I hadn't heard that, but I just wanted to make sure if that was a myth.
Wow.
What the morphine that we have, that we bring in, is in small doses. It's liquid, and it's sublingual, so it's right under the tongue. If you've ever seen it, you could just drop a little dropper of it, and they tell you how much. And that little drop of morphine frequently will help calm a person if they're having shortness of breath, or like we call air hunger, like where they're just not able to get it and they're not resting. That little bit of morphine can open those little air sacs in the lungs and just cause them to relax enough to breathe better. So we use it as much for that as anything. I mean, obviously, pain and anxiety control can help also, but I just wanted to dispel that in case anyone else had that idea that's why we use morphine. That really bothered me. So, but no, we just like to have it in case it's needed. And some people will never need it, but it's just there if you need it. Okay. Now moving on to pain. The patient is really the only one to know how bad the pain is. There's people that I've seen, I know I admitted a lady recently that was so brave, and they had actually sent her home from a cancer treatment center, and you could just tell that she was probably in immense pain, but she didn't want to burden her family with it. She was trying to so you have to really get to know that person, and the nurse will get to know them very well because they see them so frequently, and make sure that if they're having pain, we're addressing that pain. And plus, if the patient is saying they're in pain and some people are like, oh, well, they've complained for years about pain, that's just them. You know what, at this point, let's just make sure they're out of pain. We don't want them sleeping all the time, but we want to make sure that they're comfortable. Okay? And just, this just gives you some tips on, reminding the patient that, you don't have to tolerate pain. If you're in pain, yes, unfortunately, with some disease processes, you're going to have pain, but we want to make sure you're as pain-free as possible. So that's a big focus for hospice. Okay? And I think this is a good tip, too. An increase in pain does not always mean the disease is progressing. It can be from so many other things, which we talked about with the comfort kit. All right? With pain medication, everyone is different in the type that they need, the amount that they need. A lot of our folks aren't able to swallow pills very well, but maybe a fentanyl patch or something to help with the pain can really be a lifesaver. So we just have to monitor that and get ahead of the pain. It's like if you've ever had a surgery or something, they say stay on top of your pain medicine. And it's because we want to make sure that they have what they need. Let's see here. Okay. So it goes on to pain medication side effects and how to deal with them. You're going to have some of these things like the drowsiness or confusion. If we see that there's an ongoing period, if a person is more drowsy, more confused, we're going to try to slack off that some because we want them to be alert and, spend the time with their family they can. The constipation, again, we're going to be monitoring the bowels, making sure they have bowel movements every 3 days at least. To make sure they're not getting too constipated. The dry mouth, we can, we have swabs, mouth swabs, as well as, other items to try to help keep that under control. And, like it talks about hallucinations and upset stomach, any of these symptoms that we're having, we want to know what they are, and then we want to try to figure out a way to manage them. Some people will have like some delusions, hallucinations towards the end of life, especially you see this with dementia, but sometimes with other illnesses too, just because of the, change in their condition. So do we need to add a little bit of like a Seroquel or Resveratrol or something like that, just to have it, because I always look at it as, if I'm having a hallucination or a delusion and I'm anxious, I'm not having a good quality of life. I mean, that goes to quality of life. So anything like that we can make sure that they're comfortable, that's what we want to try to do. So we can call the doctor, you can keep your doctor too. With ours, I know you can't. And we can call them and say, Dr. So-and-so, Maggie is just really having, very confused, what do you suggest? This is what we're thinking. And we can try to help with that as well. So, yeah.
Do you have a social worker on your team as well? Because
Yes.
I know a lot of families, one child will want the medication, another will say, oh no, she's going to get addicted, I don't want to have that stuff.
Right.
So,
yes, we
do you
absolutely
work with the
do.
family?
We have MSWs on staff, and yes, we do. And there's some families that the social worker will just make a once a month visit, see how they're doing. They're doing great. They don't need anything, and you're off. But that's not the norm. Most of the time, it's, like you said, and it's always amazing to me, some of the family dynamics that I walk into. And you all know those situations. And I think that's why it's so important to have things like this, where you can start thinking way ahead of time, okay, this is what I'm thinking will work, and then how do I need to talk to mom and dad about it while they're still able to make those decisions. But yeah, those types of things we have our social worker's name is Anna, and she's great. But yeah, she does a lot of family conferences. She can do everything from helping people try to set up power of attorneys, to applying for Medicaid, to setting down and having family conferences, to, it's everybody's different on what they need. Some people just need that person to talk to, and they're great for that too. So, she handles our area. And so she just goes out every day. That's what she does, is make 4 or 5 visits to folks and just spends time and makes sure they have what they need. So yeah, definitely and we've had to do phone conferences from, there's a daughter here and a son here, and you just have to come and do a teleconference or Skype. Nowadays you do Skype. So, we can do anything like that that's needed, and try to provide that education. What I find a lot is sometimes the caregiver is here taking care of mom, but the brother who hasn't seen her in 2 years out here is the one that's stirring up everything.
Oh, yeah.
That's how it tends to be. And they haven't seen mom. They remember mom very differently. And so they're like, what are you trying to do? Hospice? What are you thinking about? That's crazy, So it's a lot of education and making them understand. So yeah, we certainly can help with that. That's a good point.
Well, I might add that before our son was released from the hospital, then we called it the IU Med Center University Hospital.
Yeah.
Then they made sure that we were connected with a private care like you're giving. And it did involve a social worker, and it was wonderful. And she could come in and talk with him, without us around. She got permission to talk with him and work with him. So, yeah, it was truly.
It's just a good resource to have.
Yeah,
We also have a chaplain
She just took care of
who
so
comes
many
in too.
things.
Right.
It was new to us, and
Well, it is
so
new.
we had that
and-
nurse coming in like 2 or 3 times a week, and then the social worker.
Right.
And so
Right.
it works.
And when you're in that state where you're so stressed because you have all of this, this end of life, and it doesn't matter. I mean, I knew so much of this. I mean, I have taught about dementia for years, and I was working in hospice at the time when my dad died. And still, I needed that constant reassurance. When it's your loved one, it's like, it doesn't matter even if you've been taught that stuff. You need somebody there to be able to bounce things off of.
He could sure carry on a conversation about anything, but she always made sure that if she talked with him personally, that I was okay with it. I was in the house, but I didn't have to sit in on all those conferences.
Sure. Yeah.
But it works. It made
And
us all happy.
Good. Well, I'm so glad you had a good experience with it. That's great. Okay. Well, the next one is just kind of talking about some pain control methods, that we have, that could be helpful. Going to the next slide, the end of life. So talking about death, we know is not easy for many people, although we all know it's going to happen to us. That's just going to be part of life. We're all gonna die. But it's really important that we're, when we have these conversations, to talk to the patient about, what do you still wish to accomplish? What do you need to ensure your life affairs are in order? Making sure that, like, they have these workshops on elder law planning and all of that kind of thing. I just encourage you to think about that now before it's later, because once a person is unable to make those decisions, it's so much harder to try to decide all of that. Who are the people you want to spend time with? And is there anything you need to resolve? And, what's going to bring pleasure to your life? Thinking about these kind of things is important, and I think all of us, I know I tend to kind of think, I'll deal with that later. But, it's something that we really need to focus on now, because none of us really know. Okay? The next slide talks about final days and signs and symptoms that the patient is close to death. I have this, I think is helpful. There are a couple of books that are very helpful as well that kind of talk about, making you aware that the things you're seeing or experiencing are normal. But, the person tends to sleep more. They might speak to people who aren't present. I've heard of, I had one family tell me that they had read in the book where there's this, I'm trying to think, it wasn't channeling, that's not the word I'm trying, but they were connecting, they were looking up and they were talking to someone, and she said she had read in the book that they were, a person when they're near end of life, they might be talking to people in heaven, and they reach, and they're seeing things, and it's hard to know for sure exactly, but that's very normal. If you see that can kind of startle people. They may eat or drink less and have trouble swallowing. They might just become more confused about where it's going on. Making a lot of different noises. That can kind of be startling if someone is kind of like a moaning, or you can think, oh, they're in pain, or they do this, but a lot of times that just noises is kind of a part of it. And losing control of the urination or bowel movements. Signs and symptoms, moving on there, is having changes in the pattern of breathing, such as long periods without breathing. That's called apnea. So a person can go, sometimes you'll see those, and they usually get longer and longer towards the end. But that is very common to have those long periods. Having the cool hands and feet, and the turning blue of the nose, mouth, fingers. You'll see some of these things towards very, very near the end. And we call that modeling. And what that tends to happen is usually it starts with the feet or the hands. They become very cold to the touch and look kind of spotted purpley, if you've seen it before. And I say that to say, because that can be very startling for someone who hasn't seen that. You don't know what's really happening. But what's happening basically is the blood is pumping to the major organs. The blood is needed there in order to keep you alive. So it's kind of going out more of your legs, your arms. So you'll see more of that happening. And generally when you start to see that modeling happening, it's usually about 48 hours before a person will pass. So it's just, some of these things you think, gosh, I don't want to think about that. But I think it's good for you to know, because if you're experiencing it, it's normal. It's part of it. Okay? So this kind of goes on. I don't want to keep you guys too long here, but what can be done for the patient in the final days? Just allowing them to, be comfortable, moistening their mouth, playing soft music that they like. Just try to think, what does this person like, and what can I do to try to make them comfortable? If you know that, inviting family and friends to come in, if you feel that would be helpful. Another big one is for families just to tell their loved one it's okay. It's okay to go. I've seen folks that just really hang on, and I don't understand. I think without going through that, you don't really understand. But there's people that will wait and wait and wait for that son or daughter to come in and be able to take time with them, and then they pass very quickly after that. It's like they give them that permission. So just telling them, and I know with my dad that was hard, because even though I was ready for him to go, he was ready to go because he was very ill. Telling my dad it was okay to go was hard, because I didn't, but at the same time you have to think, I need him to understand that he doesn't have to be here. It's okay, because it's time. So, that's something to think about as well. This next slide is when death occurs. And this is something that is another one that you're like, oh my, but this really can be helpful if, sometimes people pass and then you'll have families saying, I don't know, they've been having those long periods of apnea. I'm not sure if they've stopped breathing. You're not able to get a heartbeat. A lot of times a person will pass with their eyes open, so they can just be fixed on a certain spot or slightly open. And a lot of times their mouth will kind of open a little bit too. So if you're seeing these signs, that's usually a sign of that a person has passed. Okay. So in the next slide, remembering to this is kind of we kind of took the whole gamut of how to start by applying or to look into evaluating for hospice through the end. But what can you do? We have those situations where we just don't know. Refer early for the patient, family, and staff to get true benefits of all the hospice service. The quicker we can come in and supply that person with that assistance, we can just help the family. We can make sure that they are as comfortable as possible for as long as possible. Focus on the word supportive care versus hospice. It's a concept of care. Hospice is, and it's to support you and the family. It's comfort care. That's what it is. Okay. And let and then focus on staying ahead of the disease process and not speeding up the patient's passing. We want to stay ahead of what we need to do to keep that person comfortable and the family comfortable. And, a family might not want anything to stop what is happening to their loved one, but they can't. But they can make sure their loved one is comfortable for whatever time they have left. We all could say, I'm sure with your son, I can't imagine losing a child, but thinking, I want to stop this, but if we know it's a situation where we can't, then we just need to think, okay, if I can't cure them, I want to keep them comfortable. So let's get some folks in here that help us with that. Okay. So just in closing here, I handed you all another sheet that says, can I see yours for just a second? Thank you. What makes a patient hospice appropriate? These are something that I just want you to take. And if you have somebody in your life or that you think, gosh, this may be a good thing for them, I wonder if they would qualify for this. Kind of look through there, and that's just kind of in very simple terms, what might make a person hospice appropriate. If you were to call me and say, hey, I'm wondering about so-and-so having this being appropriate, and I've said something to them, and they're open to talking to you. My cards are on the back. I'll be happy always to go out and talk to somebody if you'd like me to. It doesn't cost anything. We can go out and just kind of gauge, and then we can even call their doctor and talk to their physician and say, hey, what do you think about this? And if we got an order from them, then we can proceed from there. So it's really that simple. So I just would encourage you that if you know somebody, and if it's not me, there's other hospices in town. We just want you to have the help that you need and to utilize this benefit because it really truly is a wonderful benefit.
Who do you sub for your durable products?
We use Home Health Depot. Yeah, is who we use. And they're out of, I believe they're out of Louisville, Kentucky, that they transfer. And so what we would do is when we order the equipment, they can have it up pretty quickly. We try to order as quick as possible.
Yeah, that's one thing I saw on the support group that I go online to do is that you have to make sure who supplies the durable equipment too, because there's some companies that are better than other companies, apparently,
Yeah. I've been very pleased, and that's a good point. I've been very pleased with ours. I always try to go in, especially at facilities, and kind of look and see what they brought in. And I've always been very impressed. Like it seems like it's pretty, durable. It doesn't look old and things of that nature. So, yeah.
Because one hospice person changed, and they said that they started getting really shoddy materials.
Well, that's something we certainly don't want. So,
but this was a for-profit hospice, so they were trying to cut costs, I guess, or something.
Oh, okay. Well, like I said, that's something to think about. But yeah, I think, and if there's something that doesn't work properly, most
anymore
places.
now you can go online and see reviews and things.
Okay. All right.
How many hospice companies are around?
Well, everybody has a little different service area. I'm with Premier. We service this area. IU Health, Hospice services. And I'm not sure exactly how far they go, but I know it's probably a couple counties here at least.
I thought it depended on what doctor you went to, who they.
Some doctors prefer certain hospices, but it's really up to the family. And I think that's one thing that families need to understand is that even if they're saying, well, I'm the medical director for this hospice, you know, you can go that way, but if you say, well, gosh, you know, my friend was on that, they didn't have a good experience, then I would look into, you know, just say, well, you know, I would really like to try this other one. And that's your right. That's a family patient right to go with, just as it is to transfer. If you're just like, I tried them and I just didn't like that nurse and I'm not happy, then transferring to another, you know, is okay. But there's, I'm just trying to think off the top of my head, Southern Care Hospice is in the area, Premier, IU Health, Gentiva, I think services this area still. Hoosier Uplands is down really just in the Orange County area, I think, maybe some Martin. So it's good to just kind of, that's why it's good to research. And like you said, look online, you know, and kind of get an idea, and then you kind of know ahead of time, especially if you think down the pike this is going to be coming. It's nice to kind of get an idea and even call somebody and say, hey, could you just, you know, and then you get a feeling. You're kind of interviewing them. Because if you wait till the last minute, sometimes you just, like you say, you're under so much stress, you're just going with whoever. And yeah, hopefully you have a good experience with any. I mean, that would be the hope. But, you know, it's just like anything else. Sometimes there's, you know.
I think in a small town like this, it's all good.
Most are, yes. Like Hoosier, I don't believe Hoosier Uplands would be because it's probably a not-for-profit.
Okay.
But yeah, most are.
They're subject to change as directors and management changes, so things go better or worse.
Right.
If we were able to put mom on hospice, I don't know. I might talk to you about that at some point.
Okay.
And she gets a UTI again. Is that a trip into IMA and lab result, or can that be?
That's us calling it an antibiotic for your mom. Because our goal would be, if we think she has a UTI, we're just going to treat the symptom. We're going to treat that with an antibiotic to help her, because anything that's for comfort, that's what we're going to do. Now, every hospice, probably, although we're all guided and governed by Medicare rules, we all may do things a little different. Of course, I'm not here to promote mine, but I like how we do things. We try to just stay on top of it, think, okay, what's going to be best for that patient, and get it for them.
The challenge with a 94-year-old who's in full plain UTI is moving.
Yeah.
Get them in
Especially in the winter.
Our goal, yeah, that's really the goal for people who are taking care of their loved one. We would hope that you would never have to take her out again. If we can just call the doc, get an order, give it to her, you know, and we can call ours.
So you guys can do the testing at home and all that stuff.
We can do
meet
that.
that every 3-month federal law for the fentanyl patch, so that she doesn't have to go in and see the doctor.
Right. Now, she can still go in and see them, but like if it's a situation like that where they're just not able, then we can make those calls to the doctor. We allow folks, of course, to keep their own physician. I mean, that's fine. And if some physicians will say, well, if you're going on hospice, I'm not going to follow you. Well, I mean, not most don't do that, but some do, and you know, that's your decision.
Means you may have had the wrong physician all along. But.
Yeah, well, and that's true, but most we don't have trouble with them. And then we also have a medical director who will come out to see the folks every 60 days following that 180-day certification. So when they do that, and they review them in meetings every week. So if we needed, we're like, you know, hey, their doctor's out of town, but she has a urinary tract infection, he can call it in for her to get it fixed. So, you know, we can even call him in the middle of the night to get something, go pick it up at CVS. So, you know, we try to stay on top of it as much as possible. Any other thoughts?
Okay, well, thank you so much, Carla. We really appreciate it. And I think we'll go ahead and break for lunch.